Now, for management of physeal injury at the lower limb, for this lecture, I'm going to use this AO classification because it's more relevant to trauma and also covers a few patterns that not covered inside Salter Harris. E1 to E4 is basically the same as Salter Harris classification. E5 and 6 is teo and also triplane fracture. E7 and E8 is a Walchen fracture and osteochondral fracture, which we do not have in Salter Harris and the rest. Now, the aim of treatment is basically to improve bone alignment and to prevent displacement. But we know that children fracture heals fast, heals well with remodeling. We also know that all intervention comes with the risk of patient. Now, to plan who to treat and how to treat, the factors involve these four types. First thing is the pattern of the fracture. We base this on classification. Number two, degree of displacement. Three, the age, because that dictates the degree of remodeling and sometimes patient and family expectation. Now, we are going to focus more on acute from operative treatment because limitation of time. Now, the healing and also remodeling depends a lot on the growth plate. So we should try to avoid injury to growth plate by these few techniques. One, if you use fixation methods, it should be smaller diameter, if possible, smooth surface, less number of fixations, reduce attempt. Now, three fixations is even safe. Three fixations with three attempts is less traumatic compared to two fixations with 20 attempts. And finally, if we have to go through physeal plate, we want to equally space them in the opposite end of the growth plate. All of us are quite familiar with upper limb supracondylar fracture, different methods of fixation patterns. In fact, in the lower limbs, distal femur, it is roughly the same. Okay. However, there is something missing. Some
तू
of us
चाबी लेके निकल जा, चाबी दे दे और निकल जा.
some of us do two lateral fixation, either parallel or divergent, but we don't do this in the distal femur. This is because elbow is the growing end of the bone. It's not the growing end of the bone. You don't have growth arrest, whereas distal femur or the knee is the growing end. Unilateral column fixation, high risk to develop growth arrest, and it may develop angulation deformity. So we don't do that. That is the main difference. Now, AOE1 or Salter Harris type 1, this is extra-articular with a lower risk of physeal injury. Quite often, we can treat non-operatively. Now, this is a 10-year-old boy with twisting injury over the ankle. So this is type 1 fracture separation. But since this is intra-articular, so it was reduced and fixed with one wire and it healed up very well. Now, this is distal femur fracture, type 1. It is quite similar to supracondylar fracture that we see in the humerus, and K. Wilkins believes that we should treat it the same way as well. So the patient should be in prone position, distract and flex like we do for the elbow, and it is unstable, so we should fix it. The only thing is the fixation, we should do cross rather than two lateral pinning because of the risk of growth arrest. Now, this 13-year-old boy had hip dislocation as well as type 1 fracture of a femur head. Although with acute correction and screw fixation, the risk of AVN, as you can see here, is really very high. Now, AO type 2 or Salter Harris type 2 fracture, it is roughly similar to type 1 except it is more stable and we have a metaphysis which can use for fixation. So 12-year-old boy with a right knee injury, Salter Harris type 2, so it can be reduced in the similar method. The only difference as type 1 is that we can fix the metaphyseal segment. It's quite stable and it healed up quite well. Now, this 9-year-old boy right ankle injury, again, Salter Harris type 2 or AO type 2 of distal tibia, close reduction, there is a gap here and there is some translation. So it needs to be opened up. Now, the surgeon make the CT scan not because to see the fracture, but to evaluate whether the metaphyseal fragment is big enough to be fixed or not. The decision is not big enough, so after open reduction, we use cross K wire, small, smooth wires from both sides of the physeal plate. Now, AOE3 or Salter Harris 3, this is intra-articular fracture. So it usually requires anatomical reduction and internal fixation. Now, this is a special example here, 6-year-old boy with a right ankle injury. Now, you compare to the opposite side, obviously, the medial malleolus is injured here. But before you do anything, are you able to reduce it better? Is fixation really necessary? Now, 6-year-old age comes in because remodeling is good. We decided non-operative treatment, just put in a cast, it healed up quite well. AOE4 or Salter Harris 4, again intra-articular fracture like type 3, except that it is not so stable proximally. It can move up. So this 10-year-old boy, the right ankle injury, the lateral malleoli we saw just now, this is medial side, small metaphyseal fragment. It is unstable, but it can be fixed through the epiphysis without disrupting the physeal plate. So this is 1 year later, we still have to monitor to make sure there is no physeal breach growing across. Now, AO5 is a tilo fracture. It is a Salter Harris type 3, but AO use 5 a separate category. It is caused by external rotation force. Now, the problem is the diagnosis is easily missed. So you see here, we need a special view to look at it. This is a good example. We can't see the fracture line at all. The only clue, there's a step in the articular surface. On the lateral view, CT scan, then you see the whole picture. Now, it can be treated without opening up because sometimes when the fragment is small, displacement is not so much. But for those people who like to rehab and go back to sports early, or the bigger the piece is big and displacement is small, it can be treated with internal fixation. Nowadays, percutaneous approach is a minimal invasive. It can be done through a small incision like this one. You see, from the small hole, the K-wire, one single K-wire can be used to reduce, to fix, as well to insert the cannulated screw. This is what you can get through that small hole. Now, AOE6 is triplane fracture. Salter Harris, it is a type 4, but this is a separate category. Mechanism of injury, age group is roughly the same as tilo fracture. This is 11-year-old girl. It's a bit early for this fracture, but it happens. On the AP view, Salter Harris type 3 looks like a tilo fracture, but on the lateral view, you see it looks like Salter Harris type 2. When you have 3 and 2, it is Salter Harris 4. It is a triplane fracture. The CT scan will tell the whole diagnosis. So this case, because of 11 years old, the physeal plate is still open. So smooth and small wires is being used. Generally, it is more common in the older children. Now we come to AOE7 or avulsion fracture. We are getting this a bit more often now because adolescent children go into sports. If the fragment displays not so much, it can be treated non-operatively with either full extension or 30-degree flexion to relax the ACL. But many people now are doing operative treatment, arthroscopically reduce it and fix using suture or screw fixation as we see over here. It allows earlier rehab and earlier back to sports. So then 11-year-old boy, this is again not common. You see there is a local tenderness after a twisting inversion injury, but you can't see very well compared to the opposite side what is the injury. Anyway, we treat as a fracture. Later, we notice it is a fracture that heals up very well, but this is again an avulsion type of injury. and this is not classified under Salter-Harris. It is in the epiphyseal plate. Now, finally, AOE8, articular fragment. Now, this is fortunately rare. There is a lot of overlapping with osteochondritis dissecans, depends on the mechanism of injury, whether there is acute trauma. But the piece is intra-articular, so treatment is roughly the same. Capitulum fracture is also fall into this group, but more commonly, it is in the adult rather than children. So type 8 fracture is fortunately less common in children. Now, fracture of the physeal plate are associated with their own sets of problems. Non-union and growth arrest, fortunately not so common, but it do happen. Like we see over here, medial malleoli fracture, treated non-operatively, it ends up the physeal or the growth plate is probably arrested, and there is a non-union over there. On the other hand, overcorrection, like this case, similar injury treated, I think there is a 4K wires there. So also end up with a physeal arrest and non-union. But more commonly, what we see is this physeal bar formation, which ends up with a progressive angulation, sometimes with a limb or bone length, bone shortening. Angulation, as we can see over here, can be quite significant. This 10-year-old boy left knee injury, yeah, quite young, but there is no real displacement. But careful look at the x-ray, you can see there are fragments over here. It's either type 2 or type 3 fracture. And then we decided at 10 not to do any intervention, just hold it with a cast. And then on follow-up, he returned only after 3 years. You see there is a physeal plate and gynovalgum deformity. But then we are very sure this is not due to intervention, but due to trauma itself. So in summary, the main objective for treatment physeal plate fracture is to improve alignment, avoid displacement when this is indicated. We know children heal fast, heal well, as long as growth plate and the other soft tissue are healthy. So when we plan to go for treatment to do this, we have to make sure we should avoid secondary injury to the growth plate. This can be achieved by careful dissection of the soft tissue when we want to reduce and proper techniques to perform internal fixation. So if there is any take-home message, we have to inform the family before you discharge a patient or put on long-term follow-up, inform the family about the risk of injury to the bone factory, which may not be obvious after months or years after initially good outcome. With that, thank you very much for your attention.
Thank you, Said.